On behalf of the IIP technical team, I welcome you to this webinar on PNF facilitatory techniques for improving trunk mobility in paraplegic patients. We are live on IIP India YouTube page. I request everyone to please subscribe to this page to get regular updates about our webinars. If you have any questions to the speaker during the presentation, please put them in the chat section. It will be addressed at the end of the presentation. Today's webinar is being organized by IIP Women's Cell Satara District of Maharashtra State in collaboration with Kim's College of Physiotherapy, Karad. So I request the moderators to please start with the session.
Yes, thank you so much, Uttara. A very good morning to one and all. As already described by Dr. Uttara, we have organized a webinar series, which is a set of 7 webinars spread over 7 days, rather spread over 4 days. Today we have 1, followed by 6 webinars in the following 3 days. Today's speaker is Dr. Sanjiv Kumar, sir, who is the principal of Kelly College of Physiotherapy. We welcome you, sir. Before proceeding with the webinar, I would like to give a brief introduction of the organizers. To start with, introducing IIP Women's Cell. IIP Women's Cell was started on 30th of May 2018. It functions under the guidance of National Head Dr. Ruchi Vaishne and IIP President Executive Dr. Sanjeev Jha. IIPWC works towards conducting public awareness camps, CME workshops. It aims at bringing together all physiotherapy professionals for sharing knowledge and improving public awareness about physiotherapy. In IIP, we have 5 zones in India with the heads for each. For the West Zone, we have Dr. Pooja Kamble with us. For the state team of IIP Women's Cell Maharashtra, it includes the state coordinator, Dr. Suvarna Ganveer, Madam, joint coordinator, Dr. Snehal Patel, sub-coordinators, Dr. Uttara Mohan, Dr. Priya Karande, and Dr. Nirali Sanghvi. In Maharashtra, IIP Women's Cell has conducted 40 plus low-cost activities in various districts. And to our credit, in the first corporate IIP conference, which was held in Indore in April 2019, Maharashtra State received the award for the best state IIPWC. I should also introduce the Satara team who is hosting this event. So the Satara team of IIP Women's Cell was set and established on 31st of January 2019 with a team of 3 members. Dr. Trupti Yadav was the coordinator and is also presently working as an assistant professor in Krishna College of Physiotherapy. Myself, Dr. Khushbu Chotai, who is a sub-coordinator of the district and an assistant professor at Krishna College of Physiotherapy, and Dr. Pallavi Kulkarni, who is a sub-coordinator for the Satara district. As the webinar is organized in collaboration with Krishna College of Physiotherapy, I would briefly like to describe the Krishna Institute of Medical Sciences deemed to be university, which was established by the visionary founder, chairman, our Honorable late Shri Jaivantrauji Bhosle, whom we call as Appa sir. Krishna Institute of Medical Sciences is presently flourishing under the guidance of Honorable Chancellor, Dr. Suresh Bhosle, Honorable Pro-Chancellor, Dr. Praveen Shingare, Honorable Principal Advisor, Dr. Ved Prakash Mishra, Honorable Vice Chancellor, Dr. Mrs. Neelam Mishra, and respected Registrar, Dr. M.B. Gorpade. University currently has PG and undergraduates and PhD in medical, dental, physiotherapy, nursing, allied science, and pharmacy, and is a host to 5,000 plus students on the environmental friendly campus. It has NABH, NABL, ISO, NIRF, NAC A accreditation. The university has excellent facilities for housing students in campus with state-of-art sports complex. College of Physiotherapy started initially under MUHS in the year 2002, and in the year 2005-06, the university achieved its dean status. It currently has undergraduate, postgraduate, and interdisciplinary PhD program. The college is headed by Dr. G. Varadarajulu from its inception. Krishna College of Physiotherapy is a pioneer institute in Maharashtra with all the facilities as per the norms of IIP and Maharashtra State OTPT Council. I'm very obliged to have the moderator, Dr. G. Varadarajulu, with us. I would like to hand over the further proceedings to Varadarajulu, sir. Over to you, sir.
So very good morning. It was a very good, very nice introduction of the IAP Women's Cell of Maharashtra and the Satara district and our own university. And thank you very much, Dr. Kushu Bhatt and all other concerned members. The main intention of organizing this webinar series in our university in collaboration with IAP WPC Women's Cell is that I wanted to bring the pioneers in the field of physiotherapy who are really true academicians and having a very good knowledge about the past, present and future of this profession. So when I'm actually planning for this webinar, I thought of certain seniors which has immediately come to my mind is Dr. Sanjiv Kumar sir, Dr. Kamal Nathan, who is professor in other universities, Dr. Snehal Deshpande madam, who is working for child health, and Signa Mehta madam is a very senior professionals. Dr. Rakesh Kumar Sinha, who is my own teacher, Dr. Saumi Sinha, who is my own teacher, and Dr. Raja, who is a senior professor and principal. So these are the initially I thought of who can definitely give a justice to my intention of bringing the pioneers in the field in a single platform of this kind of a webinar series. Now, to begin with, we have an excellent orator and a senior academician and administrator in the field of physiotherapy who is a well-wisher of many physiotherapists across the country and especially to me in this region, Dr. Sanjiv Kumar sir. Dr. Sanjiv Kumar sir is very what we can say a lively professionals who whatever the time, whichever time that anybody goes to his help or suggestion or guidelines, he is the first person who always say yes and guide us in a proper way, whoever it matters. So Dr. Sanjiv Kumar sir served in this field in the organization of KLE University for the past more than around 20 years, according to my knowledge. And he is heading the institution initially at the Hubli, then he is now presently heading the institution of KLE Physiotherapy, Belgaum. And sir is a undergraduate from a very pioneer institution in India, that is NIOH, and he is postgraduated, PhD, and a senior, one single word to say, a man with a global vision on our profession, along with me. So, sir is a very knowledgeable neurophysiotherapist, and he can guide us in the topic of PNF, on today's topic of PNF facilitatory technique, especially for a paraplegic children. So we all know Dr. Sanjiv Kumar sir very well, and we wholeheartedly on behalf of the Krishna College of Physiotherapy, Kim Tim University, and Satara district of IAP, and Indian Association of Physiotherapy, Women's Cell of IAP. So we wholeheartedly welcome you, sir, and we would like to know your professional experience from your words. I cordially welcome you, sir. Over to you, sir, Dr. Sanjiv Kumar sir.
Thank you very much, Dr. Varadarajulu, and quite extensive explanation you have given. I am not that great. Okay, so let us come to this webinar. I must thank IAP Women's Cell Satara District, Maharashtra, and also the Krishna Institute of Physiotherapy, Karad. Some time back, Dr. Varadarajulu contacted me about this particular webinar, and I really agreed for this. And earlier, what was my conversation with sir? It was basically for, I think, student mass. I don't know how many students are there in this particular gathering. Can organizer tell me something about how many professionals we are having in this? and how many students we are having in this. Accordingly, I will keep changing the things as far as PPT is concerned.
Sir, actually, almost more than 100 means UG and PG students from our college has joined. And
So presently we are having 193 participants.
Exactly. So let us have the presentation. What I am going to have will be addressing the need of a therapist and need of a student, even final year students, PG first year, second year, new entrant of the physiotherapy, as well as will be helping the people who are already practicing. I'm sure that people must be practicing PNF, though it is now slowly getting little less value compared to other technique like Bobath and other things. So if the organizer permits, then I'll share my slides through the share screen. It's okay if I share my
Yes, sir.
PPT.
Yes, sir.
Yeah. So very interesting topic asked by Dr. Vazlu, that is PNF facilitatory technique for improving trunk mobility paraplegic patients. Here I have divided the whole presentation into three sections. Section 1, something about spinal cord or otherwise paraplegia, something about PNF, and then finally about how exactly we are using the PNF. That means the first two portion may be for the students and the last portion will be for everyone. Uh, Now, to begin with, we all are aware that when we are talking about the paraplegics, how does the paraplegia do occur? So there are two basic reasons, either a traumatic issue or otherwise a non-traumatic issues. So when we are talking about the traumatic issues, it is mostly because of accident and other things. And when we are talking about non-traumatic issues, they are basically either because of infective origin or because of a tumor origin or because of a sclerosing region, or maybe because of dementing. So basically is what, either it is traumatic or a non-traumatic. If the spinal cord is involved, the patient will end up either with quadriplegia status or otherwise will end up with paraplegia status. So when we are talking about the paraplegia, when we talk about the Indian context, the majority of the patient basically belongs to traumatic origin paraplegia. I'll just tell you few things in brief about the traumatic paraplegia. This particular photograph is taken from a website, and it is just giving an impression, or I'm not teaching here the MRI, I'm just giving an impression how exactly the situation. If you just see this, as well as if you see this, okay, those who all are the students, if they can just notice this part, if you see this something cord like thing, and this is what is spinal cord, and if you see here, there is a fracture and dislocation, there is a complete dislocation. Now what is the status of the cord? You see the cord is completely cut and damaged. That means now this is going to have the problem anything below this. So the problem related to the sensory or motor, whatever is there, will be hampered below this. If you see this particular thing, now here also if you see, there is a very strong problem. There is a interior wedging is taking place, and this wedging has caused posterior shifting of this particular vertebra, and this vertebra shifted back, and see this is the cord, and the cord is cut. Now I am not showing this photograph for the purpose that I am going to teach you MRI or something like that. I am just putting this for one very basic purpose, that yeah, this is what is spinal cord and this is what is going to cause the problem. Most of the traumatic case will be visualized like this, but if you see the non-traumatic cases, it will not visualize like this. This will remain straight, and there may be some changes in the spinal cord. You can be able to see either some whitening is there, or otherwise some swelling is there, or otherwise some changes you can be able to see, which will be a physical changes inside the spinal cord. Now what is the issue? The cord is located in a hard tube. Now this hard tube is not expandable, so there is a space, that space is having some fluid, and there is some more space after that. So this space is the area which is giving a shocking for or shock absorbing for this particular spinal cord in any type of translation. So when you are talking about developing a traumatic issue, yeah, we are aware that now it is directly damaging the cord. But when you are talking about the non-traumatic issue, It is not directly damaging the cord, it is affecting the cord, and the reaction of the effect is causing the problem with that of the cord. And so what is happening below that particular area of the issue, the problems starts coming. Now I'll tell you one simple example. If you can take transverse myelitis, one very interesting case, normally all of you must have seen, though it is rare, but you will see that at a particular level and below that the activity is subsided. Though it is not a issue which is completely damaging the cord, but because of the inflammation and otherwise causing the increase in the space area and conflict of it, this is causing a pressure on the cord, and that is why the patients are getting problems below that particular level. So my interest for giving this information is that, yeah, traumatic issue, this problem is going to happen in the cord. Non-traumatic issue, there will be changes in the cord which will be taking, and that is why the patient will end up with some symptoms. So little bit about the traumatic issues, though I don't want you to explain all this, because I know that most of you are aware. Most of the issues arises from the motor vehicle accident. And motor vehicle accident in India, what is the scenario? If a motor vehicle accident takes place, immediately the passerby or nearby, whoever is standing there, they will immediately catch the fellow and will say, okay, get up. Now, very interesting thing you have to understand is the patient met with a road traffic accident, do not change or manipulate the patient. If you change or manipulate the patient, though patient may not be having any issue of the spinal cord, but because of your manipulation and because of your irresponsible behavior of making the patient stand or trying to make that patient walk, may likely to end up with spinal cord injury. So if the patient met with a motor vehicle accident, please stabilize the patient and vacate. Now, this why I am saying so, because maybe there are 5% of the cases which are having direct impact and damage. Maybe 10% of the cases which are having direct impact and damage. But not all 47% cases are having direct impact and damage. The damage arises because you manipulate, and there will be shift in the things will take place, and which will end up with the compression to the cord. So here, very simple suggestion. Yes, motor vehicle accident, fall from the height, any violence, any sports activity, please first try to vacate the patient, evacuate in as it is the patient it was in that particular position. Mostly it is issue concerning with a young age group, and males are more affected than females. Now, once you got the patient, and again, I am telling you, this is just the out of context I am talking about. If you get the patient, do some assessment and come to a conclusion, okay, this is the situation in this particular patient. And then you also find out what is the reason for the injury, whether it is a hyperflexion injury, hyperextension injury, axial loading or penetrating injury, or whatever type of injury, just identify. The whole idea of why to identify this type of things, because you will be able to understand very well, yes, this may be causing this type of problem. I'll just give you an example. Like for example, hyperflexion injury. When you're talking about hyperflexion injury, the flexion of spine, which is beyond the normal limit. Now, if it is beyond the normal limit, every spinal body has got a particular amount of resilience. So it will take some amount of shock. There is something which is in between the two spinal body. They will also take some amount of shock. But then when it comes to adjusting the huge amount of shock, yeah, it cannot adjust. So if it cannot adjust, what is going to happen? It will collapse. So whenever there is a flexion injury, it is going to collapse the anterior part of the vertebra. And if it collapses the anterior part of the vertebra, it is a tendency of the vertebra. If you press from the front, it will move back. Now, if it moves back, it likely to cause problem concerning to the whatever structure is there behind the vertebral body. So what is behind the vertebral body? The spinal cord. So the moment vertebral body is pushed back, it will be hitting hard on the spinal cord, and so the patient will end up with spinal cord injury. It is just example like that. Hyperflexion injury, axial loading, other things are there. I am sure that you are aware about this. We are aware about this all issue as far as type of injury is concerned. So what happens once injury is taken place? Once injury is taken place, some changes will occur. I am sure that all of you are aware about these all things. And I'm sure you all are aware about changes normally takes place in such patients. I'll just give you a brief outline, because Okay, there may be spinal shock stage and there may be return of reflex and exhaustion. But what exactly happened at the time of injury? So at the time of injury or at the time of infection, at the time of injury, there is immediate damage to the cord. After immediate damage of the cord, that particular cord will call a chemical reaction, and that chemical reaction will bring about the inflammation. And once that inflammation comes in, it will cause several different types of things. So there is a concussion, there is hemorrhage, and there is a chemical changes takes place. Believe it or not, if you control the edema and if you align the spinal cord in a proper manner, likely that outcome will be good. But normally the time lapse becomes too much. So you have to see that how fast the patient with spinal cord injury is being taken to the hospital and how early the edema at the spinal cord is being controlled. If not, you understand, if the moment you lapse with the duration, more amount of necrosis of the spinal cord likely to arise. And there will be, as I told you, there will be chemical poisoning will be taking place at that particular site. So I wanted to finish the spinal cord portion a little fast. So almost I have done with the spinal cord. So now what happens? There are different levels and there are different level of injury. As the topic which is been given to me, it is concerning with the mobility in case of paraplegia. By using what? By using PNF. So that means we are now going to target on what? We are going to target on the patients who are having paraplegia. So if anybody is having cervical involvement, it will be having tetraplegia or quadriplegia. If anybody is involving below that, if anybody is having involvement below that, it will be ending up with a paraplegia. Now here, very interesting thing, I have just put up the level and the issues. Now, if a person reaches to a injury T1 and below, these all patient will end up with paraplegia, maybe involving the chest or otherwise involving the intrinsic or extrinsic muscles of the respiration. So what is important here, I am not going to talk anything about the patient who is having C1 to C8 injury, C1 to C7 injury or C1 to C8 segment involvement. So I am going to talk about anything, whatever is there below the T1 and below that. Now, what is important here as far as these injuries are concerned? Now you see, I think this photograph will get anywhere. You will realize that the moment you come to T6, moment you come to T1, that means the moment you come over here, you will be getting paraplegia-like situation. And some will be associated with the problem associated with the chest muscles, the muscles which all are there in the rib cage. And then lower part anyway it is effective. So paraplegia, now I have given some features and I don't think so it is required right now to discuss with what all will be the feature. You understand basically if the patient is having T1 involvement and below that will be having paraplegia. Can we give everyone similar type of therapy? Answer that sorry. No, we cannot give everyone similar type of therapy. Can we give everyone same type of PNF? Answer that no, we cannot give same type of PNF to everyone. What we are actually intended to, I'll talk to when we are going to deliberate upon PNF. So let us deliberate upon some part of PNF first. So I am sure that now, by now you must be aware that T1 and below that there will be problems. What problems? I think you all are aware, as because I learned that most of you are either postgraduate or maybe a professional or maybe more than that. So you are aware that if T1 is there, what problems will be there? If T6 is there, what problems will be there? If T12 is there, what problems will be there? And so on. So that means you have some idea, okay, what all I am likely to get. Then what we should do, once patient is received, we should do some amount of assessment. What assessment? Trunk mobility assessment. What assessment? Functional assessment. What assessment? Activity patient is able to perform from his upper. Understand, when we are talking about the paraplegia, T1 and below, that means hands are okay. Of course, T1, if I am talking some part of the upper limb also definitely do have involvement, but then grossly the patient is paraplegic. That means we are supposed to tackle a patient from the point of view of paraplegia. But then there is an issue. Issue is what? If it is traumatic, T1 to anywhere down, how fast we should move? Question one. Second is that if it is non-traumatic, how fast we should move. So understand a common and gross thing about it. If it is non-traumatic, move same day, no issue. If it is traumatic, don't move same day. You wait for the healing. If the internal fixators are being fixed, I am not asking you for bony healing now. If the internal fixators are fixed, you can go ahead with your program. You have to avoid one part of it, that is trunk rotation. Now, if you avoid trunk rotation, how to give PNF then? So there you have to be selective how exactly you are going to give the PNF to those patients. Okay, so you did some assessment of this spinal cord patients. You assessed mobility of the trunk. I'm sure you must be aware about it. And you also assessed the functional part of the patient. That means what all function he is able to perform on bed, off bed, or in whatever position. So this is, I'm sure. And apart from this, you must have assessed the strength of the muscle which all are not effective. So now let us come to PNF. Again, I am sure that all of you are aware about the basic part of PNF. This basic part of PNF is basically for targeting the students who are in final year or otherwise maybe in post-graduation. So when you are talking about the PNF, what exactly we do? We use a particular type of movements. We use a particular type of technique. When we are talking about the movement, it's a pattern. When you are talking about the pattern, it's not isolated pattern. So it is a mass movement pattern. That means we are going to utilize multiple movement to treat one particular type of situation. Now, again, I'll tell you, must be coming in mind, okay, I am going to treat upper limb. So if it is coming in your mind, please remove it from your mind, because you are not, absolutely not treating upper limb. Whenever you are treating a patient by using PNF, you are treating as body as a whole. So you are supposed to keep in mind. So I just wanted to read for you, that is general principle. Why? Because I want to stress a bit on this, because it will be utilized when we are going to take up with the technique. So the treatment approach is always positive. And when we are talking, it is always positive and reinforcing. And when you are talking about the positive and reinforcing, what does it mean? I believe all of you are aware. Positive means it is towards the improvement, and reinforcing means one movement is helped by the other. One muscle is helped by the other. And that is why what exactly you are going to have this, because of this reinforcement and positive type of input, the patient will be having dual effect. What are the two effects? Physical and psychological. So this will help the patient to improve upon. The second part is that primary goal of all the treatment is to help the patient achieve the highest level of function. And third is that PNF is integrated approach. Each treatment is directed to a whole, everybody, I mean, full body, and being not a specific to, I have already told some of this part. So you have to understand, when you are giving the PNF, see that you are actually implementing it in toto, and you have to see that what you are implementing, you are trying to achieve what you are intended to. So that is what is important when we are talking about the introducing or implementing PNF treatment or treatment technique is concerned. So this is basically for PG and final years. They can ask me question also later on if they have something. Physiological principle, all of you are aware. I am not going to deliberate, but I am going to deliberate about prerequisite. When you are talking about the prerequisite, don't jump to conclusion. Yes, I am going to give PNF to this patient. No, you have done one assessment. Yes, what you understood, what you did, strength you assessed. Where strength you have assessed? Upper limb and the part whichever is spared. The part which is affected, you may not be able to assess the strength, because they may either go for spasticity or flaccidity. So one thing you have done is that strength assessment. Then you have done is the functional assessment, and then you have done the other part of assessment. What else other part of the assessment? So you have also done about the general part of the assessment for the patient. So functional assessment, strength assessment, mobility assessment, general part of the assessment. General, I am not worried. I am worried about the strength, I am worried about mobility, and I am worried about functional. So we will be targeting these three things. So if you want a person to be trained for this, what you feel it, you should be looking in the patient. If you ask me, I'll be looking in the patient. Is patient able to initiate? If the patient is able to initiate, yes, I will try these techniques. If the patient is not able to initiate, can we try this technique? I think some part of the technique we'll try. Like for example, if I can give a quick stretch, or I can give a quick elongation, or I can give a quick pull. And that means we will give some part of facilitatory technique here to initiate the movement if there is a problem with strength. If the strength is there, can we use it to transfer for some other activity? That I'll see. Yes, if I can transfer that particular strength for some other activity, I'll use that. Like for example, if I can transfer the strength of the upper limb for getting the movement in the trunk, yes, I am going to use it. Then I'll also see, can I use my head and neck for transferring the strength or for transferring the movement to my upper trunk? Yes, I am going to use it. 12 बजे बाद आइए आपका कर लीजिए पहले. So that definitely we are going to look for, and then based upon that we will be actually planning for our treatment or methodology of treatment. So that is why I have put up 3 basic prerequisites. What 3 basic prerequisites? Demand of activity, voluntary control, intact neuromuscular mechanism. Now what does each of this mean? Just now I state what does each of this means. When you say demand of activity, I want this particular part to move, I want my body to move, I want my neck to move, I want to sit down, I want to turn, I want to roll. Yes, these are the demand for activity. That means you are trying to do these things, you are anticipating to perform this. Second is that voluntary control. There should be some amount of voluntary movements. If there is negligible voluntary movement other than quick stretch, nothing can be helping you. But definitely yes, if there is a strength, there is a voluntary control, you can be able to go ahead. And very interesting, the intact neuromuscular mechanism. Intact neuromuscular mechanism, if the patient is having spasticity, I think, I am afraid, may not be utilized. It is absolute placidity. Again, I am afraid, we may not be able to utilize it. So we have to be very careful while selecting the patient. Please remember, selecting the patient, you can have a separate webinar. You can ask somebody else who can deliberate on how to select a patient for this type of treatment, because that itself is going to take long period of time. So I given some information about the PNF, and also I just try to tell you that whenever you are giving PNF, they are basically mass movement pattern. So they are not individual movements, they are combination of 2 or 3 movements. So that means whenever you will be performing, you will be facilitating 2 or 3 or maybe more than that muscles. You may be facilitating 2, 3 or 4 groups of muscles. So anyway, let us come to the actual part of PNF. So what all you are going to utilize, what all things you are going to utilize to facilitate. So there are some stimulus which you are going to give. Now please remember, many times people confuse this. No, stimulus means it is going towards some sensory technique like roots. So no, there are some stimulus which you are going to stimulate, which you are going to use. But of course, there is nothing very odd stimulus which cannot be done during the technique. So you can do some stimulus which can very well be there. Like for example, there are some extero stimulus are there. So you can give your hand itself will give the stimulus. You can have a proper eye contact with the patient, that will give the patient a visual stimulus. You should talk to the patient in a proper manner, that will give a auditory stimulus. Now, here I have to tell you one very simple thing. If in case you are having wrong tactile contact, you are going to miss the actual amount of response. If you are having no visual contact with the patient's cooperation is totally doubtful. And also if you are not having a good command, the command should be such, the patient should be encouraged to do. Command should not be such that is as if it is demanding, or otherwise command should not be such that as if you are begging. So your command should be such that patient should get facilitated to perform. These all are the external stimulus which you are requiring while performing the PNF. And there are certain things which will be coming from patient's body within, and they are resistance, approximation, traction, elongation, stretch stimulus, and irradiation reinforcement. Other things are also there. And I'm very much sure that you all are aware about all these things. So we are going to use some stimuli, and also we are going to use some part of internal, external stimuli and position of the patient. So those all we are going to add up and utilize for the patient's improvement. Now let us come to actual topic which is there for today, is about, okay, how to improve the trunk, how to improve the function of the trunk. That is a very important aspects. There are three things which we normally look for if a patient comes with paraplegia. Normally we look for three things. How is the breathing of the patient? Is the patient able to breathe normally, or is the patient has got some abnormal breathing? Again, I said that I am not deliberating how to select the patient. I am just trying to give you a brief information that what we should look for. We should look whether the breathing is good and fine. Second, why we should look for breathing, I want to ask. Anyway, I'll answer first. Later on, you all can ask with me this. Why we should look for the breathing? Now you have to see whether the upper part of the chest, whether the movement is adequate. That means muscles are doing good, muscles are working, not working. This is one part. Second, is breathing is sufficient enough that he can be able to sustain your exercise, because your exercise will be mostly resisted. So what you are going to see, breathing is good. If the breathing is good, vital is good. If vital is good, can patient sustain the exercises what you are trying to do? If not, can you tone down your exercises? That you are going to see as far as breathing aspect is concerned. Second part is that strengthening. Now, actually not strengthening, strength. You should see how is the strength of the neck, how is the strength of upper limb, how is the strength of the part which is unaffected. And based upon that, you select what particular pattern you are going to use, what particular technique you are going to use. That is what you are going to identify. And third important thing is mobility. How mobile the trunk is. Now again, I am going back to some time back. I said traumatic, non-traumatic. Traumatic, post-operative, non-healed case, avoid involving the trunk. Traumatic, post-operative, healed case, use PNF. So again, I am repeating, please don't do the mistake that traumatic, non-healed, utilizing resistance. Traumatic, healed, utilize resistance. So one case which is not healed, don't utilize, which is healed, utilize resistance. In fact, maybe your surgeon will not agree to allow you to mobilize the part of the trunk which is not fixed immediately after operation. I don't know how cooperative the neurosurgeon may be, or it's also not the matter of cooperation, it's the matter of outcome. So we have to see. So there are three things which you are going to assess, and there are different ways of assessing. Please forgive me, I am not going to deliberate on the assessment part. So how is the breathing, how is the strength, and how is the mobility? This you have seen. After that, you can start about giving the therapy. Now, before starting the therapy, I wanted to give you some information about some of the work which is done by different authors. Why I wanted to give this, that I have seen people saying many times, there is no role of PNF in spinal cord injury. Many times I have seen. I don't know, but every time I keep telling them, it is not like that. You can utilize very judiciously the PNF and can have very good improvement in the patient. And that is why I have just to put my point forth. This is one study in which the effect of PNF technique for increasing functional activity in patient after an incomplete spinal cord injury is been done by one of the researchers. Details I have given. The result was what? This study shows that PNF is having some good and positive effect. Now, what does it mean? It only means we can use PNF even in case of spinal cord injury. So I just wanted to put up this point to those who all used to say always that, okay, PNF no use in spinal cord. Yes, PNF there is use in spinal cord, and it is having multifaceted use. I have also avoided talking much about breathing aspect of PNF. I'll talk later on. This is another study. In this, they have used elastic band. That means TheraBand they have used, and they again proved that it is definitely going to help the patient to improve about the function in by using the PNF. Then there is one study which is done by us, our institute, and in that they have used trunk control assessment they have done by using the PNF, and they could see that yes, it has got a good effect on patients. And there is one more study. This is also about elastic resistance, and this also proved that there is a good effect of PNF as far as spinal cord injury is concerned. So my whole idea to put forth to you is that yes, we are going to use the PNF, and main intention of using PNF is that improve the mobility of the trunk, improve the strength of the trunk, neck and upper limb. So now let us come to the training of a patient, training a paraplegic patient who all are having issue concerning with the trunk. Paraplegic anticipate always both lower limb, maybe some part of the trunk is involved. So we can use for them neck patterns, we can use for them neck for trunk pattern, we can use for them upper limb pattern. So we can use pure neck pattern, neck for trunk, and we can use pure upper limb pattern. We can use chopping and other things also. I'll deliberate upon all of this one by one. So again, I'll request you to kindly forgive me. Right now, because of Corona situation, I am not putting any patients' photographs here. So this is very interesting thing. If you can just see, uh, I'll tell you a few more thing here. Position of the patient. If you see, it is angle in a particular angle, and step is the standing is by step standing, and grip is at the chin and other at occiput. What we are going to do? Flexion, lateral flexion. Now you may be thinking, what is that? Lateral and flexion. And so the patient will be doing what? He will be flexing the neck and also lateral flexion. If you apply resistance, the patient likely to get lifted this particular part of the area. Now, if it gets lifted, you can initiate your rolling training by this particular technique. So again, I am telling this is not technique, this is a pattern. Now what you are doing, you are giving resistance. Where you are giving resistance? At this particular point. And also you are controlling by this particular hand. When you are asking the patient, okay, you do flexion of the neck and lateral flex and do left rotation. And if you resist, then gradually patient will come up from one side in this particular manner. So what we are intended to get? We are intended to get number one, activation of the neck muscle. Number two, activation of the upper trunk muscle. And this is what we are achieving from this particular pattern. Let us see the other one. Now this is also the reverse of it. The patient has lifted up and he is now going to reverse it. Now when person reverse it, so you remember the person has gone this side, and while returning, this will be resisting, this will be controlling. And when patient goes back, he will be performing a flattening or otherwise turning to the other side. So one case turning up and going back. So turning up, one pattern, going back. Activation, neck muscle, activation, upper part muscle, movement, neck, movement, upper trunk. So you are used a particular pattern. You are going to use a facilitatory technique here by means of giving a resistance and by means of giving quick elongation or otherwise a lengthening. You are going to get activation of the muscles of the neck and muscles of the upper trunk. So this is one of the method, one of the pattern. This is another pattern. Now when you are talking about this pattern, so this pattern actually I would have shown later on. In fact, let us see if I have just put up, then we'll see this one. Now what exactly is happening here? The patient was in prone line. From prone line, patient has been brought to the pronon elbow, and pronon elbow, you see, the grip you see at occiput and chin. What is being asked the patient to be done? Same neck pattern. So this is a neck pattern on trunk or pure neck pattern in pronon elbow. What is achieved? The achievement, if you can very well see, the patient can turn from the upper. Now, if you resist adequately, patient will be turning whole body to one side. So this is what we achieved by this particular pattern. What is activated? Neck muscle. What is activated? Upper trunk muscles. What is activated? Movement here. What is activated? Movement here. What is activated? The strengthening here. What is activated? The strengthening. I mean, you have to see critically what exactly you can achieve from here. Now you see the other example here. Patient is in sideline position, and then again neck pattern we are using occiput head. Patient is supposed to turn the turn the head to one side and flex to the same side, and then you see what is the situation. Patient from sideline can turn to spine. So that means we are training what? We are training rolling, that is from supine to sideline, sideline to prone line to sideline, sideline to again supine. That means these all things you can train just by PNF. And same time we'll be activating what? We'll be activating the strength of the muscle. We'll be activating what? We'll be activating some of the more muscles of the upper trunk and lower trunk. This is another method which is used for most of these paraplegic patients. In fact, invariably we have used for the patients, particularly with the lower cord involvement. That is those who all are having say L3, L4 or L1, L2. Those involvement, they do it very effectively only after settlement of their spinal injuries. So now you see this method is known as chopping. Now whenever you are talking about the chopping, both the upper limb will be involved, and the patient will be performing in diagonal pattern, and both the upper limb will be performing in two different patterns. Okay, so if you see, both will go for extension, but both will not go for symmetrical pattern. They are asymmetrical in the nature. Patient will be asked to take this upper limb to the opposite side of the pelvis. So you see, so when patient is doing so, what you are going to do? You are going to resist it. See what we are doing? We are resisting it. See what is happening here. So if your resistance is sufficient enough, it will help the patient to come up and maybe up to sitting. So that means we are using this technique for the purpose of making the patient sit down. So you see again, there is resistance applied here as well as here. The patient is asked to lift the limb and take it across to the other side of the pelvis. Patient will be performing this. The thing which we are going to apply is the resistance, and the technique which you are going to apply preferably from unidirectional or bidirectional. That means you can do with reversal, or you cannot do with without reversal, or you can do with one direction movement. So when the patient is performing this, apply resistance and see that the patient will be very effectively lifting the upper part of the trunk, maybe as much as he can come up to the sitting position. So this is another thing which is there in the patient, which can be utilized for this patient by PNF. Now we can use the scapular part of the pattern. So we use just now about the neck pattern, and we use the chopping and lifting, those patterns. When you say chopping, it will help the patient to come up. When you say lifting, it will help the patient to go back. So that means you can help the patient in turning, rolling, sitting. This much things you can be able to perform. So far we have deliberated in these points. Now next is about the patterns which is concerning with scapula. Now here you just see this. This is what is known as anterior elevation scapular pattern. So what is the effect of this anterior elevation? If you have performed any time, you will realize that you are putting your hand, it is over the acromion, and the patient will be performing elevation anterior. That means he will be performing movement something like this. So movement of the scapula in forward direction. What effect it will have? So if the patient is in sideline, if I put the patient in prone line, and if I use this technique, then patient will try to move the body. If the patient is in supine line, if I use same technique in supine line, patient will try to come up from the upper part of the trunk. Reverse of this is that the patient is already up, or patient is already in half line or in side line. If you apply posterior depression. Now in this, patient will try to push it backward. Now if the patient pushes back, he can turn the trunk. So here what you are getting a trunk mobility in forward direction by anterior elevation, backward direction by posterior depression. Please correct, this is not posterior elevation, this is posterior depression. So what we achieved just by scapula, we can do the rolling in the from one side to other, and from other side to in the normal or previous position. See the other one, example, that is rolling back. Now here if you see, this is posterior elevation. The patient will work in the direction of therapist. And when he will do this, again patient will be able to turn back to supine line position. Here it is. So this is posterior elevation. This is not posterior elevation. This is, I think there is a mistake here. This is posterior elevation. This is anterior depression. The anterior depression means the hand will be in this particular direction. If you see the grip is under the axilla. So if it is under the axilla, what the patient is what you are supposed to do, you are supposed to pull it towards yourself, and the patient is supposed to take it towards the forward direction. So here both of this will be helping. This will be helping the patient to go back, and this will be helping the patient to come forward. So I'm going to go back again, just return here. So neck pattern, what you can use it, this is basically for neck movement and as well as upper trunk movement. So they are, you can use flexion, left lateral flexion with rotation. You can reverse it by extension, right lateral flexion, right rotation. You can use neck for trunk flexion extension. You can use neck for trunk lateral flexion. This all I have shown just now. So neck for right lateral. So if you see here, this is neck for trunk rotation, neck rotation, and trunk up, turning of the trunk, and otherwise lifting of the upper trunk. Now if you see here, again lifting of the neck, lifting of the trunk, and taking it back. And then if you see in this turning of the trunk, lifting of the trunk, here if you see turning of the neck and turning back of the trunk. Here if you see chopping, patient can come up to sit, chopping, patient can come up to sit, lifting, patient can go back to lying position. Then this is about the anterior elevation. Here basically upper trunk turning by anterior elevation, reverse is posterior depression, and posterior elevation, reverse is anterior depression, and this both will be helping the patient for turning the upper part of the head. Apart from this, you can use rolling forward by upper limb pattern, that is flexion, adduction, external. And now here what we can do, one hand, one upper limb with this, if you just perform extension, adduction, you can make the patient bring down. That means he can lift his upper trunk and go for turning to one side. If you go back and resist, patient can go back to the supine line. Similarly, for rolling back, reverse pattern can be utilized. There are many more patterns are available in this and which can be utilized. And also there are many things are there in this. We cannot cover everything in short note, but then I definitely want to open it for discussion after 2-3 minutes, because we are almost having end of the session nearly. Now the other issue is what nowadays it is a fashion of using elastic. I have not put up anything. I have just put a photograph over here. You can use elastic if there is you are having shortage of time and there are many patients you want to treat for. Then you fix a band, fix at the bed end, and let the patient to perform the exercise and help themselves. So let us have a some summing up. Before summing up, again I want to have some more discussion. Supine to sitting. Supine to sitting, definitely not from prone and elbow. Prone and elbow will help you to come for side sitting. Supine to sitting is very interesting. You use neck and upper limb pattern. Symmetrical upper limb pattern also will help. Now symmetrical upper limb pattern. Now if you are having this pattern from here, and when you are going to move forward, if you are being resisted, then you can easily be able to come up for sitting. If you are being asked to do cross pattern, that is chopping, that will also help you to come up for sitting. If you are reversing the chopping and doing lifting, you can go back. If you are doing symmetrical and resisted, you will be able to make yourself sit. If you are going back, you can lie down. Like that, there are many things which can be used. Again, I am making it very clear caution to all of you. Do not be enthusiastic if the patient is under healing period. Otherwise, you will be in trouble. So simple is that patient well healed, start giving this training as early as possible. Now next one is that you can use breathing also. Now breathing, Remember, we have said about paraplegics. That means lower limb has to be well supported, and patient can be performed bilateral upper limb pattern. If the patient performs bilateral upper limb pattern, patient can easily be able to perform sitting as well, bridging as well as sitting. So I have given a very brief information, but I want to open it if there is a discussion. Otherwise, I will deliberate on many things are still there which can be deliberated. So I am summing up this whole session is like this. You should have to understand some concept of spinal cord injury. You have to identify a paraplegic. You have to identify what all issue the patient is having. Can patient will be able to be helped by PNF technique or cannot be helped? If it can be helped, which particular pattern we should use has to be selected very carefully and cautiously. Once you select the pattern, do not try to imagine that next day patient will be perfectly normal. No, it will take time, but slowly you introduce the part of these patterns. Slowly you introduce which particular technique you want to introduce upon. Then, so important is that identify what is the problem, identify what patterns you are going to use, identify what facilitatory technique you are going to use, and then you start with this particular part of treatment. So this is about a brief presentation. I will open it for discussion. We can have a discussion. We have sufficient time now. If any questions, anything is there, coordinator can come up.
So very nice presentation, sir. And you see, actually, it is a need of the hour because today's people who are attended is, as you rightly said, they are all undergraduate students, postgraduate students, some of the junior physiotherapists across the Maharashtra and Karnataka, and of course the seniors are also who knows you well, wanted to learn from you. They are all in the they are attending the lecture. Initially, the my main intention of wants you to speak on this topic is that the importance of trunk for performing the various functional activities. That has to be very much understood to the younger generations. They just neglect how much is the trunk is important. When this trunk is actually getting affected, and how to facilitate it. So what are the different methods are available? Because trunk is very directly affected when there is a damage to spinal cord. So people of the youngsters, they will be definitely have a confusion what to do with this kind. They will become panic. In fact, if they really wanted to be a practice as a neurophysiotherapist, definitely they will be panic. And now cord is been damaged, and neurosurgeons and orthopedic surgeons they don't allow us to touch at these circumstances. What to do, and whether we can help that patients. So you are given definitely a hope to the younger generation that yes, there is a chance that where you can definitely activate the neck, activate the segments which are intact, functionally intact. Whose segments se leke aage kaisa badhane ka, you are very well explained, sir, and thank you very much. And very clear, crystal clear explanation to the people who are attending. And I think Dr. Suraj can say over to you, and you can take up the question section, where we can have a further more discussion also.
Yes, sir. Sanju sir, thank you for your valuable knowledge that you have shared with all of us. All must have resourced many new concepts from your today's webinar. There are few questions from the participants. Sir, I'm audible to you, sir?
Yeah, please.
Yes, sir. Sir, one question from Akshay Rupanawar is how to correct intact neuromuscular mechanism with the help of PNF technique?
How to correct what?
Intact neuromuscular mechanism with the help of PNF.
No, if it is intact, there is no need of correction. If it is not intact, then there is a need for correction. Okay, now if it is not intact, what is not intact, that we have to see. Whether the sensory component is not intact or a motor component is not intact. If the sensory component is not intact, first we have to give some sensory technique. And if it is motor component is not intact, then we can start up with the PNF part of pattern itself. So if it is intact, nothing is required. Facilitation you can do. If it is not intact, what is not intact, that we have to tackle first.
Okay, sir. So there's, thank you, sir. There's one more question. Has modern PNF adapting task-oriented approaches towards neurological patients?
First thing that I will tell you, whether it is modern or old, both are actually deliberating. I think if you all have read through the PNF and if you have worked on the PNF, almost everywhere the end part of the PNF is what? From gross to fine. That means we try to perform the task-oriented work also at the end. And there is some very interesting components are there, complete functional training just by PNF. So that is what I'll say. Yes, definitely will help the patient for improving about the past. Task.
Okay, sir. Thank you. So next
Now,
question.
yeah, tell me.
Yeah, so there's one more question regarding how to improve breathing in patients who are admitted in intensive care unit with help of PNF technique.
You are talking about breathing,
Yes, sir.
chest expansion,
Yeah,
right?
yes, sir.
So if see, it is very good technique. In fact, I just wanted to put up some time. If you are talking about the breathing, there are various techniques. Even if the patient is unconscious, yes, PNF definitely do have a play the role. What you are supposed to do, you are supposed to give the resistance, intercostal resistance, or otherwise diaphragmatic resistance, which definitely helps the patient for improving the breathing capacity is concerned. There are various techniques, there are various patterns are there in PNF, like external pattern is there, the costal pattern is there, the diaphragmatic patterns are there. Even patient who all are not very much conscious can also be utilized with this, and that will definitely help the patient to improve upon the breathing part of it. Hello, call me after 10 minutes.
Okay,
Yes,
sir.
sir.
Thank you.
Next question, please.
The next question. Can PNF techniques be used in meningomyelocele operated childs?
I have no idea, so I cannot say anything.
Okay, sir. Next question is, sir, generally how many minimum repetitions will help when you're using PNF techniques in neurologically ill patients?
See, I'll tell you one very simple thing. There are two aspects of the dosing, is not it? How you dose. One is a conventional method of dosing. When you are saying conventional method, gradually we go by 5 to 40. Okay, that means start with 5 contraction, go to 40 contraction. This is one conventional method. And other thing is that go by exercise prescription. So normally, initially, we always tell our students go by conventional 5 to 40. And if you are sufficiently aware about, then you can go by what ACSM guidelines suggest. Based upon that, you frame the repetition.
Okay, sir. Thank you. So one more question. How does PNF actually works in facilitation in patients with spinal cord injury?
No, PNF does not have separate way of facilitation for spinal cord injury. It is having similar way of facilitation, how it facilitates to other. Now, if you talk about facilitation, there are different techniques are there, list of events are there. Of that, one example I have given is the resistance itself is a facilitation. Or there are several stimuli there that helps for facilitation. So it is no way different than facilitating a hemiplegic. Paraplegic also will be facilitated in the similar manner.
Okay, sir. Thank you. Sir, what are the contraindications of PNF while you're implementing PNF on patients?
There is multiple contraindications for PNF, and in fact precaution I'll say, or in fact I'll say limitation, that you cannot give it to a patient who is having flaccidity. You cannot apply to the patient who is having a very acute injury. You cannot apply to a patient who is having open issues, open wounds and all. You cannot apply to a patient with a pregnant uterus or something like that, which is in the third stage of trimester. And like that, there are many things are there where you can either use with precaution, otherwise don't use the PNF. Even the cases where the fatigability is early, there also you should have to avoid the PNF. So those are the things where you can avoid giving PNF.
Okay, sir. Sir, then uh,
Yeah,
how to apply pelvic floor PNF? Is there any role of pelvic floor?
there is two different techniques for pelvic floor PNF, and of course it is beyond the domain of right now discussion. One is used for training the controlling of the urine, another is for training about the controlling of the motion. So there are different methods for that. and this is beyond the domain of this particular discussion.
Okay,
Yeah.
sir. So
Dr.
what is
Suraj,
the
Dr. Suraj,
what
uh,
is minimum manual muscle grade required in order to perform or apply PNF technique?
See, I have told earlier also, if the patient is not having any control also, not having any strength, you can use quick stretch technique. Other than that, nothing can be applied until as the patient is having some amount of initiation of the movement. That means around 2 minus or 1 plus or something like that. But again, I cannot predict it because PNF, when it was developed for polio, but later on it was taken for stroke. So in stroke, it is said that until the patient is having some amount of movement or control, here stroke, when you are talking about the control, go by Brunstrom control. And then if the patient is having at least mass movement pattern, you can use this particular technique. But for now as the person is asking in the terms of MRP, so I mean muscle strength. So I am going to just tell that if the patient is having around 2 minus, you can be able to utilize this particular technique.
Okay, sir. Sir, can PNF be applied in patients with who are having permanent implants?
PNF can be applied to any patient with a permanent healed implant. Okay. Now again, I am telling even for spine as well as for lower limb also, it can be utilized if they are having properly healed permanent implant. Do not do rotation in a long implants. I mean, this is my experience. I have not read in any book, but long implants, if you do rotation, there are issues.
Okay, sir. And sir, does PNF have any role in thoracic kyphotic patients?
I have no idea about it.
Okay. So are the mechanisms which are used in PNF are generally the same for spinal cord injuries like stretch reflexes?
Yes, yes, yes. See, there are
Okay.
no two. There are no two PNF. One is for spinal cord. One is for stroke. One is for MS. No, there is one single PNF, one single concept, and same concept is applicable across.
Okay, sir. Sir, there are few more questions.
Yes, yes. Ask, no problem.
How PNF can be used for gait training? Can it
Yeah,
help
PNF
in?
can very well be used for gait training. There are, as I told you some time back only, there are functional training, there are complete functional training patterns are there, where you can train a patient from supine line to standing to walking. And there are sequence of training for gait training. And if you want me to deliberate upon gait training, you have one more webinar, I will deliberate upon gait training.
Yes, sir.
Yeah.
Yes, sir. Thank you very much for
Yeah.
answering
Anyone
that.
have any other question? Please ask, no issue.
to add on, Dr. Sur, one of the candidates' question of contraindications, just I wanted to add with sir that we have to ensure for the spinal cord stability. So it should not, our movement patterns, our method that we are using, that should not further damage the cord. That if we ensure, then there will not be any problem of giving these things. So PNF patterns. That's just for a add-on to complete it, the answer. And any more questions are there, Dr. Suraj?
S- So, for foot drop, there's one question recently posted. For foot drop, what is the role of PNF?
See, for foot drop, again, I am telling you, if the patient is having weakness and foot drop, we can do something with PNF. If the patient is having flaccid foot drop, we cannot do anything.
Okay, sir.
If there is a weakness of tibialis anterior, yes, we can do something with PNF. If it is absolute flaccid, there is no role of PNF for absolute flaccid cases of any origin. Okay, you can give quick stretches, that's it. Even that also depends upon if neuromuscular integrity is maintained. If it is not maintained, you try, it is not going to help you. Earlier, we had a very big issues about the facial palsy, you know. People used to write every time, Bell's palsy, give PNF. Later on, it was proved that Bell's palsy, there is no role of PNF until unless the tone comes. Once the tone comes and some amount of movement develops, yes, then the role of PNF comes. That is facial PNF.
Okay, sir. Yes, sir. Can PNF be useful in laminectomy patients with no control? That's one question from one participant.
No control means,
No muscular control below.
see, whatever is below the level of lesion, nothing can be done. Whatever above the lesion, something can be done. So whatever above the lesion, yes, we will help the activities. Below the lesion, PNF will not help, but something else will help.
Okay, sir.
Thank you
Yes,
so
sir.
much, Surat sir. Thank you, sir, for answering all the questions. I would now request Varadarajulu sir to deliver the vote of thanks.
So after listening to a lucid and excellent presentation by Dr. Sanjiv Kumar sir, I'm overwhelmed with the added knowledge in these COVID-19 situations. And wholeheartedly thank you, sir, for being as an important, experienced resource person of this webinar series. And I thank the IAP central body, even the Maharashtra Women's Cell and Satara District Women's Cell for being a part of this, for partnering this particular webinar series. And I thank all the participants who are patiently listening even till now. And with your overwhelming response of asking very relevant questions. And I hope this particular session has been really enlighten you. Hope the justice has been given to the topic and for this venture. Once again, I thank Dr. Sanjiv Kumar sir, all the people involved for your cordial support on this. Thank you very much.
Thank you, sir. Thank you, all the participants. With this, we end our webinar.